Oh,
I'd like to say it's my pleasure to introduce Dr. David D'Adamo. He's the newest addition to the Dana-Farber Cancer Institute Center for Sarcoma and Bone Oncology Medical Oncology team. We're honored to have him. He's joined us from Memorial Sloan Kettering. He's a very seasoned and experienced medical oncologist. He's already offered a little different perspective, which we really appreciate. He's going to talk more about the clinical aspects of GIST and about a couple of the FDA-approved drugs, and take it away, David.
Thank you for that introduction, James. I'm going to kind of do the basic stuff about GIST, really research that's gone on from about 2000 to maybe 2006. So many of you who've been to these talks in the past, this may be all familiar to you, an old hat. But for people who are new, or maybe just to give a different perspective on things you may have already heard, I'm just going to cover some of the mostly the Gleevec era of GIST, and a little bit about other sarcomas. So sarcomas are tumors of soft tissue or connective tissue. They come from the mesenchyme, or the middle embryonic layer. These are tumors of bone, cartilage, smooth muscle, connective tissue, fibrous tissue. About 3/4 of sarcomas come from soft tissue, and about 1/4 are from bone. These account for less than 1% of all cancers, and there are probably about 50 different types of sarcomas. GISTs have been recognized. We knew that these tumors existed for a long time, but for many, many years these were thought to be leiomyosarcomas, or tumors of the smooth muscle, because they arise in the smooth muscle wall of the intestinal tract. We used to think that there were less than 1,000 a year diagnosed in the U.S., but over the last 5 or 10 years we realized that we've been underdiagnosing these by a factor of 3- to 4-fold. And so there are several thousand cases a year. And the presentation can be very variable. It can be a painless abdominal mass. It can be a GI bleed, particularly an occult bleed. These tumors can start in the small intestine, and our upper and lower endoscopies are good for seeing the stomach and the colon, but nothing in between. So they can be hard to find. They can, when they get big, they can perforate or block the intestines, or they can be painful. Or, as Dr. Rout mentioned, they can be discovered incidentally because people are having an abdominal surgery or procedure for something else. This is a microarray analysis. This is kind of a high-tech, high-throughput screen. This was done a number of years ago by a former fellow at Memorial. And this is just looking at the expression of thousands of genes and saying, gee, where do these things fall out? And so if you look at GIST and compare them to other cancers, they clearly cluster inside of sarcoma. But these are all sarcomas, and these green dots here are all GIST. And so you just ask the computer, gee, where do these things fall? And you see that they really are a distinct type of sarcoma. And these are different from liposarcoma and leiomyosarcoma and some of the others. And just even a computer can tell these apart, but obviously we rely on our pathologists. These are composed of spindle cells mostly. Sometimes they can be epithelioid. As I said, most of the protein expression is, or by immunohistochemical stains, they look like sarcomas. And the vast majority are positive for c-KIT, or also called CD117, and this is what distinguishes GIST from leiomyosarcoma. They can have a highly variable biologic behavior. As you said, when these things become spread, they can grow very quickly. But some people have very indolent tumors. Some of these small tumors, it can be years or even decades before they recur. About 2/3 of GIST start in the stomach. About 1/4 start in the small intestine. And another 5 to 10% happen in the colon, esophagus, or other parts along the intestinal tract. Fortunately, I haven't seen a lot of this lately, but we used to see people who'd have a sarcoma in an arm or leg, and somebody would do some KIT staining and be faintly positive, and they'd call it a GIST. It is a gastrointestinal stromal tumor, so it's got to start somewhere in the gut. If it's outside of the belly, then it's not a GIST. This is just another picture for the pathologist. This is taken from Chris Corliss' review a number of years ago. This is a low-risk gastrointestinal stromal tumor. This is a leiomyoma, which is a benign tumor of smooth muscle, or a fibroid. This is a high-risk GIST, and this is leiomyosarcoma, or true smooth muscle cancer. And to my untrained eye, this all looks like bubble gum, and that's why it's really important to have a good pathologist review these carefully. Just start from the interstitial cell of Cajal. Cajal was a neuroanatomist 100 years ago who stained microscope slides with silver, and he got beautiful pictures of the nervous system. But it turns out that there are these stains, that there are these cells in the wall of the gut that generate the peristaltic waves that push the food forward, that stained with silver but weren't hooked up to the nervous system. This is the paper that first identified these cells, these rare cells in the intestinal wall as the origin for GIST, and here's the KIT staining. What is KIT? KIT is a protein that starts on the outside of a cell, goes through the cell membrane, and goes to the inside of the cell. And this is a signaling molecule. These tyrosine kinases are very important molecules. We've sequenced the whole human genome now. There are 30,000 genes. 500 of them are on-off switches called kinases, and only 100 of them are tyrosine kinases. And these are master regulatory molecules. And these determine the on-off switch for cell growth. So when it's on, the cell is getting a signal to grow. It divides and forms daughter cells. And when it's off, the cell is in a quiescent state. This has a normal ligand or protein called stem cell factor that binds the outside of the protein and transmits that signal into the cell. About 80% of GISTs have mutations in this enzyme, and it is a gain of function or a dominant mutation, so that it gets a new ability to transmit these signals. Most of these are point mutations or small deletions. And this cartoon shows where most of these mutations happen. They happen in this juxtamembrane domain, right between the inside and the outside of the cell. About 2/3 of them are here just inside the cell, another maybe 15 to 20% here just outside the cell, and there's a smattering of other mutations. And interestingly, about 5 to 10% of GISTs have mutations in a different tyrosine kinase called the platelet-derived growth factor receptor, or PDGFR. And some of these are sensitive to Imatinib and some are not. Before 2000, about all we could do for GIST was surgery. Those were the only people who had any effect on these tumors. The high-grade, large tumors, almost always standard chemotherapy, doxorubicin and ifosfamide, kind of our standard, what we just threw at all sarcomas, didn't work. There's one response reported from a Mayo Clinic series a number of years ago. Actually, a review from here showed nobody responding to standard chemotherapy. And everybody progressed pretty much as soon as you did the next CAT scan in 1.5 to 2 months, and survival was poor. This is a trial of a drug. I actually forget what the drug was, but in GIST in 2002, in the pre-Gleevec era, and you see everybody progressed within 2 months, and maybe one person had one of these low-grade tumors. Until along came this medicine, Imatinib, or it was also known as STI-571, or its trade name is Gleevec. And this is a very specific blocker of a couple of those tyrosine kinases. You see this BCR-ABL up here, which is mutated in a different type of cancer called chronic myelogenous leukemia, or CML. And that's the first disease that Gleevec became FDA approved for. This was a type of leukemia. People get bone marrow transplants and be on interferon, and the remission rate with this pill was greater than 90%. We also see that it was very specific here for c-KIT with the driver of growth in GIST. And these are some other unrelated tyrosine kinases like the insulin receptor, epidermal growth factor receptor, which are important in a number of other cancers. There's some lung cancers and stuff. And this is 100 to 1,000 times more specific for KIT than these other tyrosine kinases. And also this very narrow spectrum of enzymes that it blocks and only hits a couple of these things. But it means that this medicine has a very favorable toxicity profile. If you're interfering with lots of physiological processes, then you have all kinds of side effects. So the first studies for Imatinib were in the laboratory of Dave Tuvison, actually downtown. He's moved a couple of times since then. The first patient was treated in Finland in 2000. Then there were a number of studies done here and in Europe that rapidly confirmed the activity of this medicine for patients with GIST that led to its FDA approval. This is a picture from the first patient who got Imatinib. This is a woman in Finland. She had a very cellular gastrointestinal stromal tumor. This was a biopsy from her liver. Ki-67 is a marker for cells that are rapidly dividing. You see almost all of these cells were rapidly dividing, and here's CD117 or c-KIT, so that they stained positive for that marker. After she was on therapy, she had gotten surgery, radiation, chemotherapy, clinical trials, and nothing had worked. She had a very dramatic partial regression of her tumor. You see that this is, there are a few viable cells, but most of these cells have dropped out or died. There's no longer this Ki-67 staining, so even the cells that were there are no longer dividing, although they do still have this c-KIT enzyme positivity. These are the results of the U.S. FINISH study, which was one of the first trials that led to the approval of the drug. We see about 85% of patients had partial remission or stabilization of their disease when treated with imatinib. This is the first report of the results that we now have 5- and 10-year results showing that many of these people are still doing well. There is some development of resistance over time, and that compares to this dot, which is what I showed from that other trial of standard chemotherapy that pretty much everybody progressed within 2 months. We do know that some of this sensitivity to imatinib is dependent on the genotype or what the exact mutation in c-KIT is. As I said, about 2/3 of people have these exon 11 mutations, and those are the most sensitive to imatinib. 3/4 or more of people will have dramatic regressions of their tumor. Exon 9 is 10 to 20% of the patients. Those are sensitive to imatinib, but less so. There may be some benefit with a higher dose of the drug. And then the patients who, you'll hear about these so-called c-KIT wild type in greater detail from some of the other speakers later today, and those are less sensitive to imatinib still. And this correlates with outcomes as well. The patients with exon 11 mutations have the longest progression-free survival, longest overall survival. Exon 9 mutations are intermediate, and when no mutation is detected, those patients do not fare as well. This slide you've already seen. This was a comparison of dosing, low-dose imatinib versus high-dose imatinib. Although there's a slight benefit in terms of progression-free survival, overall survival is unchanged. So we tend to start people all at the lower dose. It's much better tolerated. About 2/3 of people started at the higher dose don't tolerate it or need dose reductions. As the other speaker said, these patients do much better on imatinib than they ever did on standard chemotherapy. This is not actually part of the trial. It wasn't a third arm, but it's just overlaid for comparison. What happens when people become resistant to imatinib? Many patients do well for years. I think my longest is I've had a patient on for 10 years. But kind of average is after a few years people do develop resistance. And multiple mechanisms have been described. Sometimes that is secondary mutations in that KIT enzyme. There are other, there can be overexpression. There may be new mutations described as well. Around 2005, a new medicine was being developed called Sunitinib. It had also letters and numbers as SU11248. This had a broader spectrum of enzymes that it inhibited, so not just c-KIT, and it seemed to be a better c-KIT inhibitor than imatinib, but also blocked blood vessel growth, blocking enzymes in the family called vascular endothelial growth factor receptor. And so the idea is that this may also inhibit the growth of the tumor by choking off the blood supply. And actually, to this day, I'm still not quite sure why Sunitinib is a better drug for GIST than Gleevec, or a more potent drug, whether it's that blood vessel blocking activity or it's all that it's a better KIT inhibitor. The early trials did show patients responding, particularly their PET scans got better, but we didn't see as many people with dramatic shrinkage of disease. The FDA asked us to do a randomized trial to prove that this medicine was effective. 2/3 of people got Sunitinib or SU11248, a third got a placebo, and people were scanned very rapidly. If they had progressive disease, we unblinded them. They were able to cross over to the active drug. This had very dramatic positive results. People did much better on much longer for the tumor to grow, and there was an even improvement in overall survival, which led to FDA approval for Sunitinib in 2006, which is only the second medicine that's FDA approved for GIST. Because it hits that broader range of enzymes, it's a more toxic drug. And people have said, well, why don't you give everybody Sunitinib up front? It causes more high blood pressure. We've seen heart damage in a few people, more fatigue, some more dermatologic effects. So even though it is a bit more potent, it's nowhere near as well tolerated, which is why it still retains its place as a second-line therapy. GIST has been a really interesting model system for those of us involved in the study of this disease and this family of diseases called sarcoma. And certainly for the patients here in this room, who have GIST. This has been these have been very transformative and important developments. But why is this important in general oncology or to the rest of us in general? And I think that it's really kind of transformed the way we think about how we treat cancer. And there are lessons that we can learn from GIST that and apply those lessons to cancer in general and other sarcomas. It's instead of just throwing darts at the wall, instead of an empiric therapy, well, we've got a new drug, I wonder if it works in disease X or Y, which is unfortunately what we often do, is to, gee, what have the guys in the laboratory learned about this disease? How can we take a hypothesis and develop that into a new treatment? And there's been a lot of back and forth between our laboratory colleagues, excuse me, and our clinical colleagues. And it's really driven our research and allowed us to become much more rational about how we develop trials. And not only can we develop better treatments that are less toxic, we can develop them really quickly. Before I came here, I used to treat a lot of colon cancer, and the first drug that was FDA approved for colon cancer is fluorouracil. It came about in the early 60s. The second drug for colon cancer that was approved was in 97. It was irinotecan. The third was oxaliplatin in around 2001. Adjuvant therapy, which Dr. Rout talked about, to prevent a cancer from coming back after surgery, was not standard for colon cancer until the early 1990s. So from first drug to second drug to adjuvant therapy was a 30 to 40 year process. And just that all happened in about 6 years. So really, and this is just as a disease that's 50 to 100 times less common than colon cancer. So I think that having this back and forth between the laboratory and the clinicians has dramatically altered how we do trials. It's taught us that targeted therapies can be very effective even when standard chemotherapy is not. If you've got a drug that responds a little bit to chemotherapy, drug A works a little bit, drug B works a little bit, trying to figure out dosing and scheduling and how to combine those is fairly straightforward. It can take a lot of patience, but if this is a disease that doesn't respond to any chemotherapy, giving more of drug X or more of drug Y or giving A, B, and C when none of them work doesn't lead to any benefit. The people that I learned medical oncology from were people who developed therapies for diseases like Hodgkin's disease or testis cancer, where they had these regimens ABVD or etoposide and platinum. And the paradigm was you gave high doses of chemotherapy at the maximum tolerated dose, which made people pretty sick. You give it for a defined period of time, 4 to 6 months. Sometimes they had some consolidation with radiation or surgery afterwards. And the goal was cure. You eradicated all the disease, any cells that had traveled, and those people often went on for many years or were cured. This is a completely different way of thinking about cancer, that maybe we aren't getting rid of everything, but our goal is to make it a chronic treatable disease. So instead of the maximum tolerated dose, it's more like what's the minimum effective dose? What's the least toxic amount of drug that's going to work for the majority of people? I have patients who are surgeons in the operating room a couple of days a week, husbands, wives, parents who are living their normal daily lives. Yeah, they may have some side effects from the medicine, but they're very tolerable, and they're not, unlike our chemotherapy patients who, look sick, they've lost their hair, they're weak, they're losing weight. These are people who you wouldn't pick out on the subway, and I think that it's really transformed the way we think about cancer, and it's been a very gratifying experience as a researcher and as a clinician. And I certainly thank the GIST support community for all the funds we've gotten from you and how this has enabled us to continue these efforts.
David, thank you. Any questions?
Sorry?
Over the years, we've heard, for many years, that the average basically number was anywhere between 5,000 and 6,000 a year. But I have to go back to one thing, though. When we all started, especially in 2001 with the clinical trials, everything was registered. Everything, all the patients were registered with the main facilities and things like that. And over the years, after the Gleevec became FDA approved, and oncologists were able to give the Gleevec to the patients and treat them and things like that, overall, I don't know why, but I have a feeling that we have reached probably over 50,000 of patients
Wow.
with GIST overall that have not been on the registry or have not been with the big facilities and things like that, and yet we always kind of go back to say the same thing. 5,000 to 6,000 people a year have been affected with GIST, when it's, I think, a much larger number. The second thing I wanted to ask is that, for instance, when we do use the Gleevec, or the Sutent for that matter, why can't we use also a secondary drug that is an inhibitor that actually will help with the dividing of the cells, like topo-TI and things like that? Is there an answer to that, for instance?
Although these drugs tend to be really well tolerated or fairly well tolerated by themselves,
Right.
anytime we start combining drugs, we can run into side effects. And so Imatinib by itself, pretty non-toxic. When we've started to combine those with chemotherapy, and you guys did some trials here, I think Suzanne looked at doxorubicin or gemcitabine with Imatinib, all of a sudden we found side effects that we didn't know about. Capillary leak syndrome or heart damage or more drop in blood counts. So they're legitimate questions, but we kind of haven't gone back to even establish the safety levels at which those can be done. And once we do that, we could think about those comparison studies, but especially because we've got a treatment, A, that's effective, and B, that it's non-toxic. It's been tough to get people to sign up for those trials. There was a trial that had been on the drawing board for many years to combine Gleevec with Avastin. Avastin's a pretty non-toxic drug, but it's an IV infusion once every 3 weeks. Well, our patients who are on Gleevec and they only see their doctor every 2 or 3 months, trying to get them to come in for an IV infusion every few weeks, and then it was going to be a randomized trial, so half the people were going to get coming into the doctor's office for a saltwater infusion, just kind of never got off the boards. So there are some toxicity and real pharmacologic issues, but there's some convenience issues as well. But I think certainly in the resistant setting, we are starting to do those combination trials.
Okay, thanks.
Other questions? If not, I think this is the point where we're going to take about a 15-minute break. We'll all rejoin back here at 11:30 and have a chance to continue on with David had started. Thank you.